Good afternoon, everyone. On behalf of the Department of Dermatology, Venereology and Nephrology, myself, Dr. Neha Taneja, Assistant Professor, I welcome you all to the CCR, wherein the first case that we'll be presenting is of a middle-aged man where the cutaneous manifestations led to the evaluation of the presence of monoclonal gammopathy and guided the further management. To present the case, I would like to invite Dr. Nidhi from our department to start with the case presentation.
Good afternoon, everyone. So our patient was a 49-year-old male whose total duration of complaints was since 1.5 years. He had complaints of itchy, erythematous, skin color, waxy papules, coalescing to form plaques and diffuse sheets of infiltrated skin, which initially started on the extensors of legs and gradually progressed to the generalized distribution. He also had complaints of exaggerated skin folds and skin binding downs since 1 year. The pruritus associated was mild and it was not interfering with the sleep. Patient had relative sparing of scalp, flexures, genitals, palms, and soles. There were no any other systemic complaints. With these complaints, patient had received multiple treatments for around 1 month. Each treatment, that is tofacitinib, isotretinoin, prednisolone with azathioprine, and oral fluazole therapy for around 1 month each treatment with minimal improvement. His comorbidities were he was a known hypertensive since 3 to 4 months, which was well controlled on tablet amlodipine 5 milligram once daily. On cutaneous examination, there was generalized involvement of trunk and extremities in the form of these small papules, which were skin color to erythematous, firm, waxy, shiny, and at places these papules were linearly arranged as shown in this figure. Patient also had a few characteristic signs. In the first image, the patient had characteristics involvement and infiltration of face leading to leonine facies. The patient also had exaggerated skin folds on the back, also known as Sharpie's sign. The patient also had infiltration on the dorsum of the fingers, leading to the characteristic donut sign. The routine investigations of the patient revealed hypercalcemia of 11.2. Rest routine investigations were within normal limits. Now I would like to call Dr. Shreya to further present the histopathological examination of the patient.
Good afternoon, everybody. Two biopsies were taken, one from upper back and another from left forearm, and the findings are like on lobar examination. We can see that this is the AB pass stain to highlight the features better. Like epidermis is mostly unremarkable with increase in this blue color substance suggestive of mucin deposition. The special stain used is AB pass to highlight the acid mucoglycoproteins. This is another picture of the same. And apart from that, another interesting finding was the increase in the fibroblast, which we can see are these stellate cells, and there is separation between them, which were highlighted as blue color on the AB pass, suggestive of increase in fibroblast as well as dermal mucin. And we can see that around these are the adnexal structures, the eccrine gland. There is no significant inflammation around it. So based on this, we had an impression of Scleromyxedema because of fibrosis and mucin deposition, and based on the clinical impression. So next will be carried on by Dr. Sen.
Good afternoon, everyone. We received peripheral blood and bone marrow sample of this patient. So in the periphery, hemoglobin was 40.7 and there was no Roulet formation in the RBCs. The total and differential leukocyte count were normal and there was no circulating plasma cells. Platelet count was adequate as well. And the bone marrow aspirate smears were particulate and cellular. In aspirate, we got about 7 to 8% plasma cells, as indicated by these arrows. In imprint, since the bone marrow representation is little better, we got around 15 to 17% of plasma cells. So this is how a plasma cell looks like: an elongated cell with an eccentrically placed round nucleus, a perinuclear half, and a basophilic cytoplasm. So these plasmas are around 15 to 17% on the imprint. This bone marrow aspirate sample was subject to flow cytometry. So the continuous events were gated, followed by the singlets, and following which we eliminate the debris. And the plasma cells are gated in the CD38 and 138 gating. The aqua blue cells in the bottom, they are the normal B cells, and the plasma cells are there in the top right in the first plot. Then following which a normal plasma cell will express 27, 81, 19, 45. These are the normal markers, and 56 will be absent. So whereas in the abnormal plasma cell, as they are highlighted with the red color, they are 19 negative and dual negative for both 27 and 81. And they also show loss of CD45 as against the normal B cells on the top right. Then in the normal plasma cells, the kappa lambda ratio was 1.1:1, whereas in the abnormal cells, the skewed ratio of 0.02:1. The bone marrow biopsy was adequate and there was no thinning of trabeculae, not suggestive of renal osteodystrophy. On IHC, CD138 highlights the plasma cells comprising 16% of all the nucleated cells, which exhibit lambda light chain restriction. So based on the morphology and the biochemical finding of 11.2 milligram per deciliter calcium, so we offer the diagnosis of multiple myeloma, following which the patient was subjected to standard myeloma therapy protocol with bortezomib, lenalidomide, and dexamethasone. Thank you.
Consented the clinical and histopathological evaluation, scleromyxedema was diagnosed, and with bone marrow biopsy involving more than 10% clonal plasma cells and hypercalcemia, final diagnosis of scleromyxedema with multiple myeloma was made. These are the cutaneous features that make us to think the monoclonal gammopathy. The Poem syndrome, characterized by glomerular hemangiomas and scleroderma skin. Tempe syndrome, characterized by mucocutaneous telangiectasia. Scleromyxedema, as described in our case. Systemic amyloidosis, characterized by periorbital purpura. Schnitzler syndrome, characterized by urticaria lesions. Necrobatic xanthogranuloma, characterized by yellow plaques around the periorbital areas. Erythema elevatum diatinum, characterized by firm papules and plaques in the extensors of joints. And SCPD, characterized by pustular eruptions. Scleromyxedema is a rare primary cutaneous mucinosis, which characterized by confluent papular and sclerotic eruptions, with it's seen most commonly in middle-aged adults with no gender or racial predilection. The criteria for scleromyxedema is generalized diffuse papular and sclerodermoid eruption and characteristic histopathological triad as explained by Dr. Shreya, and monoclonal gammopathy with absence of thyroid disorder. The pathogenesis involved in scleromyxedema is dysregulated cytokine stimulation and plasma cell monoclonal gammopathy, which leads to glycosaminoglycan synthesis and fibroblast proliferation. The cutaneous features was described by Dr. Nidhi, characterized by firm waxy close-spaced dome-shaped papules arranged in a linear pattern and in a sclerodermoid background with Sharpie cell and Downet cell and Leonine facies, usually with or without loss of hair over the sclerodermoid plaques. The systemic manifestation includes central nervous system involvement known as dermatological syndrome, characterized by stroke, seizures, memory loss. Peripheral nervous system involvement in the form of carpal tunnel syndrome and peripheral sensory motor neuropathy. Musculoskeletal system in the form of arthralgia and proximal muscle weakness. cardiovascular system in the form of heart block, pericardial effusion, respiratory system in the form of obstructive and restrictive lung disease, GI involvement in the form of esophageal dysmotility, and ocular in the form of ectropion and corneal obesities. The histopathology is characteristic of mucin deposition in the papillary and mid-dermis with fibrosis and fibroblast proliferation. Usually, when we suspect seromyxedema, we evaluate for the serum protein immunoelectrophoresis and immunofixation, and urine protein electrophoresis and immunofixation, and serum free light chain and quantification of the immunoglobulins will be done. Additional imaging and test of extracutaneous involvement is done based on the symptoms of specific organ involvement in the form of HRCT, 2D echo, PET scan, serum calcium, and DEXA scan. There are various criteria for the paraproteinemia. If more than 10% bone marrow plasma cells is there, then considered as multiple myeloma. If less than 10%, it is considered as monoclonal gammopathy of undetermined significance. In our patient, the patient bone marrow was showing more than 10% of plasma cells with features of hypercalcemia. Other features which can be included are renal insufficiency, anemia, and bone lytic lesions. The treatment option depends on the whether seromyxedema without paraproteinemia or with paraproteinemia. Usually, without paraproteinemia, the skin-directed therapy includes retinoids, poor therapy. Paraproteinemia directed includes IVIG, bortezomib, lenalidomide, dexamethasone combination, or stem cell transplant. These are the various studies which states the response with the skin improvement, systemic involvement, and monoclonal gammopathy with the therapy. The response with the monotherapy with IVIG and lenalidomide for the skin is around 69 to 70%, while with combination of IVIG with steroid or IVIG with lenalidomide, IVIG with melphalan was around 100% in the skin and systemic involvement. Overall, there is no head-to-head comparison in the various therapies since it is a very rare disease. And this is the current response after 3 cycles of combination therapy. And we can note there is reduction in the skin thickening and reduction in the density of papules. Pruritus, yes, ma'am. There was a significant improvement in the pruritus. Thank you so much. We invite the queries and the questions there from the audience. So for the multiple myeloma in this patient, the 6 cycles have been planned, and depending upon the response, the repeat hematological investigations will be done again. And later on, if the skin manifestations still remain, then the other skin directed therapy. My impression is not going it to be or a mild appearing. No, ma'am. The skin manifestations usually do not, they are not directly correlated with the systemic manifestations, either hematological or other systemic manifestations. But the presence of scleromyxedema, whenever we are suspecting, then the patient is evaluated systemically, especially for the hematological changes. And depending upon the symptoms, the other symptoms need to be. Selvan, can you share your experience in patients where we suspect either monoclonal clamidity or unsignificant significance or multiple
Actually, sorry, I am from the lab side. The clinical hematologist is they are taking an interview right now. So that part I'm sure. The treatment part I'm not sure. Like if there is any query regarding the investigations, I'm more than happy to.
Thank you.
Sorry.
So for NGUS, so then there are no clear-cut guidelines, and skin-directed therapy also takes care of the hematological side also. So there we can treat with either corticosteroids or IVIG or rituximab or the other agents as mentioned like lenalidomide or melphalan.
For example, many artists are it show that this is the environment is
So the progress has not been defined in literature, but annually they have to be followed up with the investigations. If they develop overt myeloma later.
smart.
Yes, so they have to be evaluated annually.
Thank you.
Thank you so much, everyone. So the case highlighted that the presence of certain cutaneous manifestations can lead us to systemic evaluation and hence the appropriate management of the patient. Thank you so much.